just move right into our next speaker, who is Dr. Joel Neal from Stanford University. He'll be talking largely about some new agents that we were hearing about that are not yet ready for prime time, but certainly look promising to many in the lung cancer community.
Thank you, Dr. West. Today I'm going to be covering some of the interesting targets in non-small cell lung cancer and some of the interesting new targeted therapies in non-small cell lung cancer. In general, these trials are somewhat smaller than the ones reviewed by Dr. Szynski, but are interesting because they may apply to specific subgroups of patients. The first trial that I'd like to talk about is one presented by Dr. Bramer in the Clinical Science Symposium at ASCO, and this is the activity and safety of anti-PD-1, which is also known as BMS 936558, in patients with non-small cell lung cancer. This was a highly anticipated trial because this is one of the first agents to show promise in immunotherapy in non-small cell lung cancer. Normally, an immune response is mediated by the interaction between antigen presented by MHC on an antigen-presenting cell and a T cell, which has co-stimulatory signals, including the T cell receptor and CD28. The secondary signals from T cells lead to activation, proliferation, migration. But interestingly, those same T cells express something called PD-1 on the surface. PD-1 is ligated or signaled by PD-L1, and many different solid tumors express this ligand for PD-1 called PD-L1 on them. What is expected is that the interaction between PD-L1 and PD-1 inhibits the T cells, causing anergy, exhaustion, and death. And therefore, PD-L1 and PD-1 are both targets for immunotherapy in all kinds of solid tumors. This agent, 936558, is a human IgG4 anti-human PD-1 blocking antibody with no known Fc function, which means that the immune cells don't themselves recognize the antibody, so all of its activity is probably on its blocking of the receptor on the cells themselves. Preliminary evidence showed that this was a safe and tolerable agent. In this trial, which included not only patients with non-small cell lung cancer, but also melanoma, renal cell cancer, colorectal cancer, and prostate cancer, patients were treated with the anti-PD-1 antibody for a continuation dosing on 8-week treatment cycles. And this trial included 122 patients with non-small cell lung cancer, stage 4, who had failed prior treatment. Patients were maintained on this, unlike many clinical trials, until they had either clinical deterioration and rapid progressive disease, unacceptable toxicity, but were allowed to stay on the study if they had progressive disease, which is in distinction to many different clinical trials where patients with progression are disallowed from continuing the therapy. The biology behind this is that an immune response may cause a transient increase in the tumor size, and therefore that may not be progression, but it may be signs of a response. So 3 different doses were tested, and on this trial, what we saw was an exciting 18% response rate across patients with non-small cell lung cancer out of 76 evaluable patients on the study. The duration of this response was variable, went from 2 months to 30 months, and many of the patients had stable disease that lasted more than 24 weeks, a little under half of these patients. Across the different doses, it looked like both the 3 milligram and the 10 milligram per kilogram doses were both active with 32 and 18% response rates respectively, but small numbers of patients, so this probably isn't different. When we look by histology, another exciting thing about this trial is it looks like both squamous and non-squamous patients had a chance of responding. So the reported response rates among squamous patients were 50% and 43% on 2 different doses, but these are small numbers, only 13 patients total. Within non-squamous and larger numbers, the response rates were 23 and 13%, still respectable for patients who could have had up to 5 prior lines of therapy, and the stable disease rates were similar. This is a spider plot presented by Dr. Bramer, and what this shows is this concept of the transient increase in disease preceding disease decrease. So I chose one of these, the 10 milligram per kilogram dose, and some of these patients had an occurrence of a new lesion, which is reflected by the transient increase here, and followed by a decrease for some of these lesions. Some of the patients with increase had actually a partial response following this. So this does go along with the potential biological effect of an inflammatory response rather than true tumor progression as the first sign of effect to this drug. Here's a clinical example of a patient who had a lesion that 2 months later grew and then 4 months later shrank. there were other lesions in a different section of the same lung, which confirmed this process. Adverse events and toxicity were generally tolerable on this agent. If we look at the total population, 64% of patients had any adverse event, and out of the lung cancer population, only 8% had a grade 3 or 4 adverse event. The grade 3 or 4 were often fatigue, diarrhea. There were 2 pneumonitis and 2 elevated AST, and I don't think we heard details on the other 1 or 2 patients with grade 3 toxicities. But in general, this looks to me like a very well-tolerated agent with some fatigue, some rash, some diarrhea, but fairly minimal and under 10% generally. In safety, the maximal tolerated dose wasn't identified, but seeing responses up to 10 milligrams per kilogram, this is a reasonable dose to move forward with. Grade 3 to 4 toxicity was relatively unusual. There was some pneumonitis or lung inflammation noted, and overall, it looked like a fairly tolerable agent. My conclusions for this is BMS 936558 appears to be tolerable and have modest toxicity. There's a strong signal of clinical benefit with a 20% response rate approximately in this relatively small series. And it works on all histologies, not just adenocarcinoma as most targeted therapies have done, but also there's a promise and a potential signal in squamous. So I am eagerly anticipating the upcoming clinical trials with this agent and other agents which target the PD-1 and PD-L1 pathway.
Thanks for listening. If you like and learn from our GraceCasts, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.